We are live.
Okay. So, good evening, postgraduates, and my respect to all the mentors. Let me welcome you all to this 109th episode of All India Ophthalmological Society's Academic and Research Committee's postgraduate teaching program. So, today is the 109th episode, and today we will be having two short cases. And today, the moderator for the whole event is going to be Dr. Tinku Bali, who is member ARC North. So without much ado, can I request Dr. Tinku to carry forward the proceedings?
Thank you, Dr. Prashant. So first of all, it's a privilege to have all the esteemed examiners and the mentors and the presenters here this evening. So this episode of the ARC AIOS PG teaching program is on a short case presentation. Now, as you know, case presentations form the very backbone of medical learning. And today's episode, we hope, will give the postgraduates an opportunity to showcase their clinical acumen, as well as receive very constructive, feedbacks from the examiners. So with that, I would like to welcome our esteemed examiner, and that is Dr. Professor Subhash Dadea, who's the director and professor at the Guru Nanak Eye Center, Mamsi, New Delhi. A very warm welcome to you, sir. Thank you so much for sparing time from your schedule to be with us, and looking forward to all your inputs and perspectives. I would also like to welcome our mentors, that is Dr. Rekha Khandelwal, who is professor and head of the department at the NKP Salve Institute of Medical Science and Research Center, Nagpur. Very warm welcome to you, ma'am. And Dr. Preeti Rawat, who's professor, Department of Ophthalmology at the MGM Medical College, Indore. Very warm welcome to you, Dr. Preeti. We have two young presenters, that is Dr. Apurva Khadakbhavi, who is a resident at the NKP Salve Institute of Medical Science and Research Center, Nagpur, and Dr. Shruti Mahajan, who is a second-year resident at the MGM Medical College, Indore. So I wish both the presenters a lot of luck in fielding the questions from the examiners. And after the case is presented by Dr. Apurva, apart from Dr. Dadea, I would also request Dr. Preeti Rawat to examine the student. And likewise, when Dr. Shruti presents, I would request Dr. Khandelwal to also join in as an examiner. So with that, we dive into the proceedings, and I request our first presenter, Dr. Apurva, to kindly share her presentation, and she'll be presenting a case of microphthalmos. So for the examiners, please feel free to interject and interrupt, or if you have any clarifications, you can always ask even in between while the presenter is presenting the case. So the first case, we'll stop when half an hour is over and start the second one.
Is my screen visible now?
It is, it is.
Good evening all. My name is Dr. Apurva Khadakbhavi. Today I'll be presenting a short case of nanophthalmos under the guidance of Dr. Rekha Khandelwal ma'am and Dr. Rutuja Dev ma'am. A 47-year-old female presented with chief complaints of gradual diminution of vision with intermittent pain and redness in both eyes since 3 to 4 years, associated with colored halos and frequent headaches, with no history of aggravating or relieving factors. She gives no history of ocular trauma and is not on any systemic treatments. Her last ocular history starts 7 years back in 2017 when she said a laser surgery for frequent pain, redness, colored halos was done in both eyes elsewhere, and she was diagnosed with glaucoma. For the next 2 years, she was asymptomatic and on regular follow-ups. But from 2020 to 23, during COVID, she missed visiting the ophthalmologist, though she had gradual progressive diminution of vision with frequent redness and pain in both eyes. From the past year, symptoms aggravated in both eyes, and she was started on multiple eye drops and was told that glaucoma has increased and referred to us for further management. She has history of spectacle use for near vision since 9 years. She gives no history of hypertension, diabetes, thyroid disorder, migraine, or bronchial asthma, and she denies of any addictions. Positive family history of glaucoma is present in her father, and there is history of small eyes in other family members and her daughter. Birth and perinatal history was uneventful and full term with no history of NICU admission and no history of viral illness. No history of consanguineous marriage and parents was there. On further inquiry, she revealed that her daughter, father, aunt, and grandmother also had small eyes and complained of intermittent ocular pain in both eyes from young age. She was accompanied by her daughter to our OP, and these are the photographs showing small eyes in the patient and her daughter. On general examination, she was conscious, oriented, moderate.
Stop for 1 minute. Stop for 1 minute. So,
Yes, sir.
based
Yes, sir.
on history, what are your differential diagnoses?
So, my differentials are first is nanophthalmos with secondary angle closure glaucoma. Second can be primary angle closure glaucoma,
But,
and it
based on history only, if a patient presents to you with history of diminution of vision and with pain, so nanophthalmos cannot be the first diagnosis, no? And that is after
yes, sir.
examination
So,
and development. So you don't assume that it was a case of nanophthalmos. You have to go by the history of the patient.
yes.
So what
So,
are the
sorry, sir.
differential diagnoses?
It can be chronic angle closure glaucoma, or it can be Plateau syndrome.
Other differential is?
The other differential is plateau iris syndrome, sir.
Okay. Anything else?
So because mm,
So what negative history will you ask other than what you have mentioned?
yes, sir. So if she had floaters and flashes of light to rule out posterior segment disorder.
Anything else?
And ruled out any redness in the eye due to uveitis
Okay.
or there can also be lens induced glaucoma in the patient.
Okay.
As she complains of his.
Complete the examination.
Yes. On general examination, she was conscious, oriented, moderately built and nourished. No pallor, icterus, clubbing, cyanosis, and regional lymphadenopathy. Pulse rate was 72 beats per minute. Blood pressure was 126 by 80 millimeters of mercury. Respiratory rate was 20 cycles per minute. Abdominal examination, CVS, CNS, and urogenital systems were normal. No skeletal, dental, or facial deformity was there. On local examination, the patient had a normal head posture with orthophoric eyes and no facial asymmetry. Ocular motility was painless and full in all directions. She had narrow palpebral fissures in both eyes. On ocular examination of right eye, best corrected visual acuity was 6 by 36 and N12 with correction of plus 1.75 diopter spherical, plus 3.75 cylindrical at 6 degrees and additional plus 1.5 diopters. Mild ciliary congestion was there. Corneas appeared small with horizontal corneal diameter of 9.5 millimeters, suggestive of microcornea with 360 degrees of peripheral stromal haze. Anterior chamber was quiet, shallow with peripheral anterior chamber depth less than 1/4 thickness of cornea, suggestive of von Erichs of grade 1. Iris was brown in color, no holes or atrophy, and patent laser peripheral iridotomy at 9 o'clock. Pupil was central, 4 mm, irregular, reacting sluggishly with loss of iris rough superiorly and showed no RAPD. Nuclear sclerosis of grade 2 was noted. Undilated fundus examination on slit lamp biomicroscopy with a 90 diopter lens showed slightly hazy media, large disc, defined margins, cup to disc ratio of 0.9:1, diffuse neuroretinal rim thinning, bayoneting of vessels were present, peripheral blood vessels and peripheral retina appeared normal as far as seen, maculofundal reflex was present, intraocular pressure measured with Goldman applanation tonometer at 11 a.m. while patient was on anti-glaucoma medications was 18 mm of Hg. On ocular examination of left eye, best corrected visual acuity was 6/24 parts and N12 with correction of plus 1.50 diopters spherical plus 4.50 diopters at diopter cylindrical at 180 degrees and additional 1 plus 1.5 diopters. Similar anterior segment findings were present as in the other eye. While intraocular pressure measured with Goldman applanation tonometer at 11 a.m. while patient was on anti-glaucoma medications was 20 millimeters of mercury. On indentation gonioscopy with Zeiss 4-mirror gonioscope, no angle structures were seen and 360 degrees of peripheral anterior synechia was present in both eyes. These are the Goldman 2-mirror gonioscopic images showing all 4 closed angles with peripheral anterior synechia. Both eyes showed advanced glaucomatous visual field defects on visual field assessment with 24-2 with mean deviation values of minus 20.63 decibels in right eye and minus 14.25 decibels in left eye. So visual field assessment with 10-2 was done to better evaluate the central field, which showed significant central field loss, more right eye more than left eye. Then retinal nerve fiber layer OCT was done. The scan quality of which was good, well centered with and with adequate signal strength. RNFL thickness map shows significant thinning in superior and inferior quadrants, which corresponds to the deviation map. RNFL thinning was noted in superior and inferior quadrants. In quadrant and clock hours, T-SNEC profile showed loss of double hump pattern in both eyes. Average RNFL thickness was noted to be 77 microns and 69 microns in right eye and left eye respectively, suggestive of advanced retinal nerve fiber layer loss in both eyes, which was correlating with the visual fields. This table summarizes the biometric and keratometric parameters of both eyes. Axial length was significantly shorter with 19.8 millimeters in both eyes, anterior chamber depth of 1.8 millimeters in both eyes. Keratometric values in right eye were 44.25 at 90 degrees and 46.25 at 180 degrees. And in left eye, they were 43.25 at 90 and 45.25 at 180 degrees. IOL power, intraocular lens power was plus 28.50 diopters and plus 29.0 diopters in left eye. Differential diagnosis, then we reached to a differential diagnosis of primary angle closure glaucoma, microphthalmos with secondary angle closure and plateau iris syndrome. Taking history, examination and investigations in autosomal dominant isolated nano advanced angle closure glaucoma with status post laser peripheral iridotomy with nuclear sclerosis in both eyes was made. She was advised. For the discussion part, this table describes the clinical spectrum of small eyes, which include simple microphthalmos, complex microphthalmos, relative anterior microphthalmos, posterior microphthalmos, and nanophthalmos. With axial length of 19.50 millimeters, horizontal corneal diameter of 9.5 millimeters, and shallow anterior chamber of VH grade 1, our patient falls under the category of nanophthalmos. nanophthalmos, where there is global reduction of the eyeball with reduction in all the parameters with thickened sclera and choroid. Nanophthalmos is a rare genetic disorder. A small eye is secondary to arrest of the growth phase after completion of normal organogenesis, restricting the normal expansion of the globe. Nanophthalmos may present as a non-syndromic, isolated nanophthalmos and syndromic. The syndromes include nanophthalmos, retinitis pigmentosa, foveoschisis, and optic Brusen syndrome, oculodentodigital syndrome, autosomal dominant vitro-choroidopathy with nanophthalmos, and Kenny-Caffey syndrome. Moving on to the genetic basis for nanophthalmos, it shows autosomal dominant inheritance with mutations in MYRF gene located on chromosome 11 and TMEM98 gene located on chromosome 17. MYRF mutations cause nanophthalmos by disrupting the normal growth phase of the eye in second trimester. Specific function of TMEM98 gene still remains unclear, but it is hypothesized to lead pathologic scleral thickening and secondary glaucoma development in nanophthalmic eyes. Autosomal recessive inheritance is seen with mutations in MFRP gene located on chromosome 11 and PRSS56 gene. MFRP gene plays an important role in maintenance of retinal pigment epithelium, which supports photoreceptor function. So mutations in this gene have been linked to autosomal recessive syndrome of nanophthalmos, retinitis pigmentosa, foveoschisis, and optic disc drusen. Decision making for management of this case depended on various factors. Then a sequential combined surgery was planned. If glaucoma is controlled and visual acuity is less due to cataract, then plan cataract extraction first. If glaucoma is uncontrolled and visual acuity is good, we can plan trabeculectomy first. Can also plan combined surgery, phacotrabeculectomy with MMC. High complication risk in all procedures is associated. The management challenges which would be faced preoperatively are unreliable keratometry and axial length measurements due to small steep corneas leading to errors in estimation of IOL powers. Intraoperative risks include shallow anterior chamber with crowded angles, small pupils even with full dilatation, and high lens to eye volume ratio, all of which could make instrument handling difficult. Postoperatively, increased IOP due to aqueous misdirection, risk of peripheral uveal effusions due to sudden lowering of intraocular pressure during or after surgery, increased incidence of postoperative inflammation can be there. These are my references.
Only thing is, classically, this in case of nanophthalmos, the axial length is usually less than 19 mm in classical case.
Yes.
And secondly, because it is because of abnormal scleral collision stagnation that leads to these things, and these nanophthalmic eyes, they are because of the shallow anterior chamber, they are prone for glaucoma, and you have to differentiate it from simple hyperopia also.
Yes.
If I may interrupt, Dr. Apurva, I request you to stop sharing a slide. Yeah.
Yes.
So in that case, the AC depth will be normal, but axial length will be shorter in case of axial hyperopia. And these sort of patients, basically cataract surgery, glaucoma surgery, first of all, you have to, because in this patient, the vision is less, so there might be some component of amblyopia also. So refractive correction, amblyopia therapy, and then cataract surgery, and subsequently glaucoma surgery, or you can do the combined surgery. These are very difficult subset of cases, and the causes are usually genetic mutations, infections, environmental factors, and systemic syndromes are there. And classical syndrome, Charge syndrome is also associated with this microphthalmos and nanophthalmos. So, very good presentation, but you have worked up this patient keeping in view that your case is of nanophthalmos. So, in exam, you should not go by the diagnosis, you have to go by history, then keep the differential diagnosis and rule out those on examination and reach to the provisional diagnosis and final diagnosis. Thank you.
Yes.
Thank you, sir. Dr. Preeti, would you like to ask some questions as an examiner?
Hello.
Yeah, Dr.
Hello.
Preeti, yeah, I request you.
Very
Yeah, we can
nice
hear you,
case.
Dr.
Very nice case presentation. जो key features that those are very important is to assess the vision, check the patient carefully, and prevent amblyopia. That is very important, and monitor for glaucoma. Regular follow-up of the patient is important, and check for glaucoma. And if a patient is having raised IOP, we have to treat accordingly, so it can prevent the vision loss. And at last, if suppose eye is very small, the cosmetic issue can be there, so we have to rehabilitate that condition also.
Thank you.
Yes.
Dr. Dadia says, is there any other question that you would like to ask her, from the exam point of view on her examination techniques or anything else? Dr. Preeti?
Actually, voice बहुत कम आ रही है. Hello.
Dr. Preeti, would you like to ask her any other question related
हाँ.
to the examination or the clinical
Actually, she
findings?
has completed all things, but how to differentiate between microphthalmos, anophthalmos, nanophthalmos? What is the basically the difference in these? When we clinically examine the patient, how will you differentiate between? Theoretically, you told everything, but clinically, when you examine, so how will you differentiate between microph, nanoph, anoph?
Ma'am, simple microphthalmos is when there is short axial length and microcornea, but anterior chamber depth is normal. But in nanophthalmos, there is global reduction in the size of the eyeball, which includes short axial length, decreased horizontal corneal diameter, as well as there is reduced anterior chamber depth. And also with that, there is thickening of the sclera and choroid to more than 1.7 millimeters.
That was a good answer. So, Dr. Nadia, any other question that you would like to ask her before we move on?
No, we can move on to the second case.
Oh. So, Dr. Rekha ma'am, why did you want to Apurva to present this case, or any other features that you would like to point out, or any other tips for the PGs that you'd like to give?
So I want thank you very much, and I just wanted her to present this because the history is very long history and one should not skip the history. She was all right for 2 years before COVID when she underwent laser procedure, and then she came after that with total angle closure. She also told that previously her symptoms of colored halos, pain, everything subsided after laser therapy for 2 years, but she was advised to have the follow-up, which she was maintaining. And later on, she landed up into complete closure of the angle. And it could be confused with plateau iris because PI is patent and the angles are still closed or the attack is not aborted. So plateau iris syndrome and plateau iris glaucoma, one should be able to understand that with patent idotomy, if the IOP is not under control, then one should think about this condition as well. For this patient, she was accompanied by her daughter. So one should also look at who is bringing, how are the eyes of someone who is accompanying your patient. Have a look at it because daughter seemed to have no symptoms. But then on probing, we came to know that 3 generations have been affected by the similar condition. That was only after looking at her daughter who was just accompanying the mother, basically, without any symptoms. And then we counseled her also to be under follow-up because she seemed to have the similar condition.
Thank you, ma'am. So very interesting case and excellently presented by Dr. Apurva. Thanks to your able mentoring. So
Thanks.
with that, congratulations, Dr. Apurva, and thank you so much. And with that, we move on to the second case, which will be presented by Dr. Preeti Rawat. And I request Dr. Preeti to, Dr. Shruti Mahajan, who has been mentored by Dr. Preeti Rawat. So Dr. Shruti, I request you to kindly share your screen.
Yes, ma'am.
And Dr. Rekha, ma'am, I request you to join in as an examiner at the end of the case. So, Dr. Shruti, your case is a case of Axenfeld-Rieger anomaly.
Yes, ma'am. Good evening, everyone. I am Dr. Shruti Mahajan, and I will be presenting a short case under the guidance of Dr. Preeti Rawat, ma'am. A 14-year-old female, a resident of Rajwada, Indore, presented to the ophthalmology OPD with the chief complaints of gradual diminution of vision in left eye since 6 months. The patient was apparently all right 6 months back when she developed experiencing diminution of vision in left eye for distance that was gradual in onset. It was associated with headache, but not associated with pain and redness or any watering, photophobia, colored halos, flashes, or floaters. Family history and past history was not significant. Birth history, it was a full-term normal delivery in hospital and was born out of a consanguineous marriage. There was no history of any antenatal infection or delayed achievements of developmental milestones. The general systemic and physical examination of the patient was within normal limits. On examination of right and left eye, the best corrected visual acuity was 6/6 in both the eyes, with a correction of plus 1.5 DS in right eye and plus 1.1 DS in left eye, plus 0.75 DC at 90-degree axis. On examination of right eye, there was a prominent cord-like structure was seen in the peripheral cornea, which was near the limbus, which is known as posterior embryotoxon. Rest of the anterior segment was within normal limits. The IOP was measured, and the corrected IOP was 14 mmHg of mercury. The AC depth was 2.8 mm. Axial length was 23.8 mm. The lens thickness was 3.8 mm. K1 and K2 were 39.50 diopters and 38.25 diopters respectively, and the central corneal thickness was 566 micrometers. On gonioscopic examination by a Goldsman 3-mirror gonioscope, we could see the tissue strands extending from the peripheral iris to the prominent Descemet's prominent Schwalbe's line, obscuring the scleral spur in the ciliary body. So only the Schwalbe's line and the trabecular meshwork was visible on gonioscopy. On examination of the left eye, again, the prominent cord-like anteriorly displaced Schwalbe's line, which you can see inferiorly, was visible, which is also known as posterior embryotoxon. Along with that, correctopia, which is the displacement of the pupil from its normal position, was seen. Iris hypoplasia was present, and posterior embryotoxon was seen. The biometry was performed, and the corrected IOP of the corrected IOP was 40 mmHg at the presentation. The AC depth was 2.51 mm. Axial length was 24 mm. Lens thickness was 3.85 millimeters. KVKH was 38 diopters and 39.25 diopters respectively, and CCT was 586 micrometers. On gonioscopic examination of the left eye, broad-based adhesions, broad anterior iris adhesions were seen in all the 360 degree in the angles with a prominent Descemet membrane, which was again obscuring the trabecular meshwork and the scleral spur. Fundus examination of both the eyes was within normal limits. So on the basis of the history and the clinical examination, the diagnosis of the right eye was Axenfeld anomaly, because only the anterior segment, anterior angle was involved, and the peripheral cornea was involved, and the left eye was Axenfeld anomaly because the iris changes were also seen in the left eye. The patient, because of the IOP of the patient was increased in the left eye. The patient was started on tablet acetazolamide 250 milligrams BD for 3 days with potassium supplementation. Locally, she was also started on eye drop travoprost once in a day. The IOP was 18 mmHg after 3 days of monitoring. After that, the oral acetazolamide was stopped and the patient was continued on eye drop travoprost. The right eye was also kept under observation, and after the resolution, after the IOP was under control, the patient was prescribed glasses. The patient was born out of 3 siblings from a consanguineous marriage. The parents and other siblings were also screened. The father, even though we wanted him to give consent, he did not consented for the procedure. Mother was 36-year-old, and the first sibling, which was a 12-year-old male, had normal IOP and normal angles. The second sibling, which was a 9-year-old female, had normal IOP, but there was an anterior insertion of iris inferiorly on the gonioscopy, and the rest angle was normal. She was also on a regular observation. So the takeaway points from this short case is that the Axenfeld-Rieger is a developmental anomaly, which is an iridotrabecular dysgenesis. The condition is bilateral, but it can be asymmetrical. 50% of the patients develop glaucoma later in life. Most common presentation is in the adolescence or early adulthood. Regular monitoring with timely interventions can prevent the irreversible blindness due to glaucoma. And it has an autosomal dominant inheritance, which warrants the screening of the family members as well. Thank you.
Thank you, Dr. Shruti, for that excellent case. I now request our examiners to ask their questions. Dr. Dadea, sir.
So, any systemic findings associated with any dental anomalies, facial anomalies, any neurological anomalies?
Yes, sir. We looked out for the systemic anomalies, but there were no systemic anomalies that was associated. That's why we didn't. We kept the diagnosis as the anomaly only, and we didn't classified it as a syndrome.
Yeah. So basically, we have to differentiate between anomaly and syndrome, and usually these patients, they are associated with dental facial anomalies, empty-sella syndromes, like Fisher is there. And in these sort of patients, you have very well explained. Most important thing is approximately 50 to 60% of the patients, they develop glaucoma, and it is usually not controlled on medications. Sooner or later, you have to do the surgical intervention and surgery with usually antimitotic agents.
Okay. Thank you, sir.
Yes.
Dr. Khandelwal, any questions you'd like to ask?
Any differentials you want to keep in mind looking at the case?
Yes, ma'am. One of the differentials could be ICE syndrome, that is iridocorneoendothelial syndrome. But since the patient had bilateral complaints, and ICE is usually unilateral, and also the ICE syndrome is an acquired abnormality, and usually is presented. The patient may present between 20 to 40 years of age. Whereas this patient was presented in childhood and early adolescence also. And the pupillary abnormalities like the correctopia is usually not present in the ICE syndrome. It usually presents with polychoria or iris atrophy, progressive iris atrophy.
They can be correctopia also, right?
Yes.
What do you get specular in ICE syndrome?
Ma'am, there is a reversal pattern which is seen in ICE syndrome. The borders are seen hypoechoic, and the inside of the cells are seen hyperechoic in case of ICE syndrome.
What are different features? What are the other features what are different types of Axenfeld-Rieger? Is there any other type, you know?
Axenfeld anomaly, Rieger anomaly, and Axenfeld syndrome. These
Okay.
are the three eponyms which are designated in this trabecular
Difference
dysgenesis.
between Axenfeld and Rieger.
Ma'am, in Axenfeld anomaly, the peripheral cornea and the chamber, the peripheral anterior chamber is involved. We can see the posterior embryotoxon, and we can see the iris strands, which extends from the peripheral iris to the prominent Schwalbe's line. Whereas in Axenfeld's anomaly, along with these abnormalities, the iris changes are also seen, like correctopia, or there could be iris atrophy or a hole formation as well.
Mm. How can you, have you done visual fields? Would you advise visual fields?
Yes, ma'am.
In the
Visual
exam,
fields
but
would.
would you like to do visual fields?
Yes, ma'am. Yes, ma'am.
And that might change the diagnosis from anomaly, right?
Yes, ma'am. Yes, ma'am.
Thank you, Dr. Rekha, ma'am. Dr. Dadia, sir, any other question?
Basically, this was a very typical case. All the clinical features of syndrome are present in this case, and a classical case with the classical presentations. So she has presented very well, and she has described all the features very well.
Yes.
No further.
I agree. Dr. Shruti, you did an excellent job, very well presented, and you fielded the questions also very confidently and gave very correct answers. Dr. Rekha, ma'am, since we have time, yeah, Dr. Preeti, anything else that you would like to add or point out, or any other tips that you've for our PGs?
I want to ask some questions to Dr. Shruti.
Yeah, sure.
Yes, ma'am.
Shruti,
Yes,
what
ma'am.
are the systemic associations we should look for in this case?
Ma'am, the patients in this syndrome usually have dental and facial bone developmental defects. In dental abnormalities, the patient might have microdontia. The patient might have hypodontia. Patient might also have anodontia. When it comes to facial abnormalities, the patient might have maxillary hypoplasia. There could be receding upper lip, or there could be prominent lower lip. There could be hypertelorism or telecanthus. Broad nasal bridge can also be present in these cases. Apart from these, because this is a developmental defect of the neural crest, the empty sella syndrome has also been seen in some of the patients.
And how will you decide when to treat medically or we have to do surgery in such cases?
Ma'am, since the patient, if the patient's IOP is well controlled by medical management, we usually don't go for the surgeries. If at all we have to do a surgery, it is very difficult to go for angle surgeries like goniotomy or trabeculotomy. So the surgery of choice is usually trabeculectomy with the use of mitomycin C or glaucoma drainage devices.
It's okay. So, Axenfeld-Rieger is a spectrum of anterior segment dysgenesis, and it is very important because 50% of the cases have chances of having glaucoma. So, early recognition and lifelong monitoring is very important. So, timely we can give medicals or timely surgical intervention is very important. So, thank you.
Thank you. Thank you, Dr. Preeti. So with that, I think we've come to the end of this case presentations. Dr. Apurva and Dr. Shruti, you both did an excellent, presentation and also fielded the questions very well. So if any one of the mentors or the examiners has any parting shots or anything else to add, most welcome. Otherwise, I think we've come to the end of this episode.
The question, one question can come in Viva is related to aniridia and Wilms tumor associated with it. Because if you get a case of Axenfeld-Rieger, then aniridia you should be knowing about.
True.
And you can get Wilms tumor in these children if you have an iridae, right?
Thank you, ma'am. So, Dr. Dhadia, anything else you'd like to add, or we should wind
No, I
up?
think it is fine. Short and sweet.
Okay. So, thank you, everyone. It's been great listening to those wonderful cases. And thank you all for your presence here this evening. With that, I bid you a very good night, and also want to remind you that we are there every Thursday from 8 to 9. We have an ARC AIOS session, and every week there's something new. So either it's a case presentation, a journal club, or it's a didactic lecture, or we unravel the intricacies of a diagnostic modality. So all these episodes are extremely useful for the postgraduates. So I request them all to be there every Thursday. So with that, thank you so much and have a very good night. Thank you.
Thank you so much. Thanks, Akeem. Thank you.